We are ready to start the next session, the second session. We will go straight to the action. And with me here is my good friend,
Hello.
Dr. Petros Odoulidis. So he has the task to start this session.
So we're going to proceed with the next case, which is a case done by Dr. Misrae, a case of green lead. Are we ready to connect to the theater?
Can you hear me?
Hello, can you hear us?
Yeah.
Hello, Dr. Misrae.
I hear you. Can you hear me?
Yes, we can.
Yeah. Okay. Good. Oh. Okay. There is a trouble. I need another fiber. The fiber is broken.
Dr. Misrae, can you please present the case?
Absolutely. Just a second, because I have a small issue with the fiber. You see the? Can you see the camera? The fiber is broke. The fiber is broken, and if I press the foot pedal to lasering, the laser will go out at this point and not at the end of the fiber, because the fiber is broke. So we need to change the fiber. So okay, stand by. Then you can remove the fiber. Put another one. Yeah. To screw. Yeah. Remove the card. Remove the card on the side. Now just put the new fiber. Now just before the fiber. Okay. Then you plug and then turn on the right side. Press and turn. Yeah, now the new card. Good. I think it would be okay now. Yeah, it's okay. Okay, it's okay. Now with the new fiber, it's okay. So the case, can you hear me?
Yes, we can hear you. Now that you mentioned it, is this a single-use fiber?
What?
Is this a single-use fiber?
Absolutely, it's a disposable fiber. So this is the 2090 fiber. This is the HPS fiber, the old generation of fiber, 120 watt fiber that can be used to enucleate the prostate. To vaporize, we use the Moxie fiber, which is the most recent. When I say most recent, the Moxie fiber has been released in 12 years ago, so it's not really recent, but it is the most recent, the Moxie. And now we use the previous version, 120 watts, the HPS version, used initially to vaporize, and now we use it to enucleate. So for this patient, the patient has been in retention 2 times, and he has a prostate of 90 grams, refractory to medication. He was under Plavix, clopidogrel, stopped a week ago. So I guess we won't be in trouble with the impaired hemostasis. And we will proceed to an enucleation for this patient. So, are you ready? So the procedure always starts at the apex. The settings are 80 watts and 40 watts for coagulation. 80 watts vapor, it's okay. 40 watts for coagulation. So always start at the apex. So we see the sphincter here, and we immediately start the delimitation immediately after the sphincter. Can you see the video? Yeah?
Yes, we have a very good view of the video.
Okay.
Thank you.
Okay. So all the point is to delimit the apical part of the prostate from the sphincter. Now we go gently. I use the coagulation mode, sometimes the vapor to do a deeper landmark according on how the technique has been described initially by Fernando. Like that. And the same maneuver on the opposite side. Okay, from the side to another of the virumontanum. Feel free to ask any questions you may would like to.
For the moment, we are just fascinated of how smooth and how sweet your motion is with the fiber.
What I can say it again, please. I cannot hear you clearly.
We are admiring your hands. You are very smooth.
Thank you. So you see the sphincter here, the landmark. I spent some time doing that. We don't want to rush the procedure, just because it's a live surgery, and then we are not in the same condition. I always remember when I started to do a workshop in my department, hosting some colleagues from everywhere, and I was thinking that, oh, okay, how good I am or how bad I am when I operate, when I have some people in the operating room, because we need to be aware of that. Okay, how are the results? And then I analyzed retrospectively the patient I operated during some workshops with some urologists in the operating room, and patients operated in normal conditions. And then I found nothing changed except the intraoperative time. So now the crucial point is to find the plane of dissection, blunt dissection. So I press a little bit laterally to the veru to find the plane, like that. Sounds to be the right plane, not too deep. Then I step back and I will detach the adenoma. I do some hemostasis, not to be overwhelmed, surrounded by small but significant bleedings. And I will detach progressively the adenoma, like that, really gently. Then I proceed to the coagulation. And again, carry on my dissection of the apex. So I didn't find any difference in terms of postoperative outcomes for patient operating during workshops and compared to normal conditions. So I published this paper in European Urology Focus. But again, it's very important to know our own results to improve. It's a never-ending story of improvements, technical improvements, to keep the patient in good safety condition. So I continue my dissection. So vaporization is only 80 watts. We see the dissection plan here. And the side-firing fiber is not a problem at all to do this maneuver. So the fibrotic tissue here. So the point always is to determine where is the good plan. Am I too deep? Am I too superficial? So always constantly ask this question: am I in the good plan? Okay. So I continue to detach the adenoma. And I do some gentle movements to detach the adenoma here at the upper part. Okay, really gently, because sometimes the capsule is really thin. There is an anterior part, a significant anterior part. Okay. And again, carry on the hemostasis. Okay, so now there are some fluffy tissues here I want to get rid of. Okay. My limit is here. So I do this very gently. I don't put any traction, any force. Coagulation. I have some small nodules here, but maybe I will left that part for the end.
Vincent, it's Jean-Baptiste.
Okay.
We see that you are detaching the sphincter at the moment at the apex at the top.
Yeah.
And you told us yesterday that in your initial experience you had 25% of incontinence after that kind of surgery. Now you probably have passed your learning curve. Have you got an idea of your incontinence rates in the first months after surgery?
Less than 2%. Because initially I was not doing that maneuver. I was not. It was 8 years ago. Okay, so 8 years ago, I published that in the Journal of Urology in 2005. 2015, but it was the patient operated in between 2012 and 2014. And at this time, I wasn't doing early apical release. So that explained, and after now more than 1,000 of procedure, I constantly asked my clinical researcher to analyze the results of incontinence. The clinical researcher is calling the patient, collecting the data more accurately sometimes than me in a consultation for some typical informations. So she's doing an amazing job, and this is completely, I don't have any regards on the data collection, because it could bias, of course, the results. If I say, okay, the patient is continent and he is not, okay, so he has some drops, some small drops that I should not consider as a real incontinence, okay, it's biased. Okay, so now I continue to dissect the apex. Oh, fibrotic tissue. This kind of prostate is, I think, a little bit much more difficult to dissect than when there is no fibrotic tissue. Always check if I'm on the right plane, but I think yes. Okay, soon I will release completely the apex. Okay. I'm eager to find a much more easy plane for the dissection. But anyway, I don't rush. I'm not rushing. Okay. Sounds better at this point. Vision is clear. So the scope I use, the resectoscope I use, is designed to allow blunt dissection with a smooth, very smooth tip and metallic tip, not in bakelite. Initially, I used the Storz instrument, but bakelite is too too sharp. Too sharp to allow a blunt dissection. Okay, I think we are approaching progressively the bladder neck. I need to dissect the upper part first. You see there is a nodules here that impair the So I progress very, very gently because the capsule seems very thin. Okay. I dissect progressively the posterior. Okay. Time to coagulate. Okay, it's very easy normally to do the hemostasis with the green light because the size of the spot is huge.
So
we can say that it's a quite different technique that we see previously because it's a lot of blunt dissection and hemostasis is section with the laser. Have you got some comments, Vincent, to tell us about this? There is a great difference in enucleation technique between direct and straight fiber laser, which is a dissection laser or combining with small blunt enucleation with thulium. And there, the technique that you show us, which is a technique with a lot of blunt enucleation. Have you got some comments about this?
I think both are efficient. Let's say at the very beginning, my incontinence rate was too much because of I didn't release the sphincter first, and when you do blunt dissection and you didn't release the sphincter, you put too much stretch on the sphincter when you dissect. But if you release the sphincter first, it's okay. But to answer your question, in fact, this is all a question of this is about how you make sure that you are in a good plan. If you cut and do the hemostasis at the same time with your laser, you have to make sure that you are in the right plan, especially at the beginning of your learning curve. Make sure of that, because you can create a plan which doesn't exist. And you will cut into the prostatic tissue in a plan that doesn't exist. So you have chance to lost in plans and to be much more deeper and to do a capsular perforation, which again is not a big deal. Making a capsular perforation is not a big deal. I was fearing about that initially, about the consequence, but honestly, the consequences are minimal if the perforation is small, of course. But I have to say that it's a different manipulation, of course, when I do two-lap. Okay, it's something to learn that you left you press the foot pedal every time, and you are in the right plane at the proper distance from the tissue. Oh. It's completely different.
It looks like a big part of the operation is being performed by feel, not by vision. Is this more difficult to teach to someone?
Sorry, say it again.
It looks like the biggest part of the operation is being performed by feel and not by vision. And I suppose that this is very difficult to teach to someone.
Yeah, right. The prostate is supposed to be a 90 gram prostate, but maybe a little bit more. I would like to make sure that I'm in the correct plane at this stage. There's some calculus. And the prostate is really fibrotic. Okay. So far, so good, but
Can I ask you a question? We noticed that you're using like more than 50% of your, during the procedure, using blunt dissection, as Dr. Roche mentioned. Is this something that you started doing from the beginning, or this is something that you started to do after experience?
no, I started from the early beginning.
Okay.
When I start to work with the Wolf instruments, because with Storz it was really impossible to make a safe blunt dissection due to the bakelite, the different shape of the tip. I'm not sure. The prostate anatomy is really not as usual. I don't like this kind of. Yeah. Okay, so you see the blue. Now I'm supposed to be in the bladder, of course, yeah. Now I have the landmarks. It could be a little bit tricky to find the bladder neck sometimes, to make sure that you are in the good plane and not you won't emerge in the radius, of course. Never happened, but always clear about that. Okay. So we have the good landmark. What I found the most easy things to do with the fiber, the green light fiber, is the coagulation, because the tip is shaped to, the spot is shaped, the spot is really large, and then to coagulate, it's easier than when the spot is really thin. I think there is a small nodules here. Again, yeah, there are some nodules attached at the upper part of the prostate. Okay. So I will complete the liberation. Grab some water. Okay. There are some nodules here. Okay. So I continue to dissect even here at the lower part of the prostate. There are some fibrotic attachments. I'm not sure it's because I'm in good plan, I think, really. But there are some fibrotic tissue that make the dissection a little bit more complex. Sometimes we can think that, okay, I'm too deep or I'm too superficial, I'm in the adenoma, but no, here not. I will cut the cresta uretralis now. At the end. I slide in the plan. There is a median lobe, I think. You see the bladder neck here, and then we have a sort of median lobe, but initially I don't saw any median lobe. Okay, so the bladder neck, I cut the bladder neck. Okay, I will release the lateral attachment. Lateral attachment. So until now we have spent 34 kilojoules only, 34 kilojoules. No, it's okay. I was just saying that we spent some limited energy. Again, the nodules just behind, just underneath the bladder neck.
That's all. Do you hear me?
Yeah.
I showed you there are some attachment on at 6 o'clock, basically, just not far from the Vermontano. Did you left them by chance or by purpose? Just to avoid the lower rotate.
What do you mean? What I left what?
Yes, I saw that you cut at last some part of the adenoma were still connected to the Vermontano, basically at 6 o'clock. It was by chance or by purpose?
Yeah. Here?
You left them it by purpose or by chance?
By purpose, by chance. I don't left the place for chance in surgery, but okay. This case, I have to admit, this case is not so easy, but I take my time. I will remove the nodule after. So far, no issues, no capsular perforation, nothing that I could fear for the outcomes. I will remove this fluffy things. Okay. Still this down. Okay. Attachment at the apex, but that sounds big to be good now. Okay. Seems to be okay. There are lots of nodules. Including this one, but I will left these nodules for later. Okay. I'm in a nice plan now. I constantly move Oh, this nodule is very, is not placed where I would like to. I have to be careful because the capsule is really thin with these kind of nodules. Okay, good. Okay. I can use the fiber like a small finger to find the good plane if I have a doubt. I always firing straight up to avoid injuries of the ureteral orifices. Okay, so the job is almost done. Still some attachments at 6 o'clock. Again, some attachments. I will check the euro after. So I peel the capsule. Oh. Okay. I can coag like that using I firing back from the area I would like to coagulate because the tip is eating the tissue and provide a good hemostasis in case of failure of the normal hemostasis mode, the pulse mode. So I will push gently the adenoma into the fossa. Now I will do the hemostasis. I want to keep the adenoma in the prostatic fossa to improve my irrigation flow and make sure that I see all the bleeders before proceeding to the morcellation. Again, another nodule. I always spend much more time for the hemostasis than initially, than when I started. A zone of frailty here, very thin. Okay. There is a small flap here. There is a small flap. Want to get rid of because this flap can impair the continence until it disappears. I remove again some small fluffy tissues with the vaporization. Okay, the edema is now flipped into the bladder. We will check the arterial orifices. Yeah, one. Where is the other? Yeah, here. The difficulty of this kind of prostate is that the aspect, the consistency, the fibrotic aspect of the prostate, and nodules, especially at the upper part of the prostate. Small flap. Okay. Sounds almost good. $60 kilojoules.
Can you please explain what means 16 kilojoules for some of us that have never used the green light?
60 kilojoules. Yeah, the fiber is limited to 400 kilojoules. 400. So we have. Unfortunately, we cannot reuse the fiber. Tons of nodules, potential beach balls that we shouldn't left in the, of course, in the bladder. Okay, I think it's time to proceed to the morcellation. Okay. No, not yet. Okay. Fair enough. Mm-hmm. I would like to play snooker. No, I won't be able to. Okay. Give me the oscillator. Please, the nephroscope. Could you raise the... Oh, no, okay, it's okay. The irrigation bags are enough higher. Of course, it's not the clopidogrel effect. That's fine. Okay. Okay. Nephroscope. Thank you. All right, it's okay. Can you help me to... Okay. Now we are ready to morcellate. Where is the foot pedal? Where is the foot pedal of the morcellator? Right side, please. Right side? Yeah. Vision is okay. I guess. No, I think there is a leakage because the bottle is filling much more faster. Can you speed down? Speed down, please. Speed down. Yeah. Here, you touch the screen. Speed down. Yeah. Il faut réduire la vitesse. Et, like that. Now you touch, tu touches le... Oui, voilà ça. En fait, 2. Tu peux appuyer sur 2. Tu fais glisser. Voilà. Non.
Tu veux combien?
Je veux la moitié. Un peu moins.
C'est 750.
Je veux 500, ouais. Exact. Voilà. Allez. Ah non. Ouais. So there is a leakage somewhere. So can you give me the... Yeah, this stuff? Yeah. There is a leakage somewhere. It's the problem with the morcellator. Sometimes.
So what speed do you use for your morcellator at the moment?
It depends. I have some leakage, some issues with leakage somewhere. I don't know where, but I noticed that the bottle is filling much faster than the collector of tissue. It looks like I have a it's the morcellator sucks more water than he chew some adenoma. Okay, you see, if I press the foot pedal, there is nothing. Yeah, the adenoma, the morcellator is not grabbing the tissue. It means that I have a leakage somewhere. But I have some troubleshootings against that, like a small sparadrap on the handpiece. Fernando taught me so much troubleshooting for morcellation, for many other things, for lasers. So you cover the handpiece with a small drape, and then it's supposed to make things easier to limit the leakage of negative pressure of suction. You see the water, the bag, the water bag is the water collector is half full, which is not a good sign. It's not a good sign. It means that there is a suction problem. So the speed morcellation, I used to morcellate with 600 rotation. So on each side it's 1,200 per minute. But when time comes to morcellate beach balls, so small nodules, it's better to decrease the rotation speed to the minimum. Well, it's better now. It's better. The efficacy is better. I wait a little bit for the bladder to be completely full. But usually, an adenoma of 100 grams, you don't need to change the water collector many times, just 2 times, or maybe only 1. But if you have to change your collector many times during the operation, it means that you should check that there is no leakage on the pipe connections.
Tu veux qu'on change le vocal?
There is no suction anymore. Yeah, you should fill out. Can you decrease the speed a little bit? More? Yeah. 400. Again, yeah. I think there are some stones inside. Much more better.
So what is your rotation speed now at the moment?
I would like to reduce the speed for beach balls, but is it some stones? I think so. No? Yeah, it's a stone. Okay. I need another laser. Or, yeah, it's a stone.
Inside the prostate?
Yeah, no, not inside the prostate. I think hidden in the somewhere in the bladder. When I check the bladder first.
Το δικό μας είναι το λέει, φαβορίτο.
I will do again. I will check the hemostasis. Okay.
The Flavix.
Maybe. Okay, we'll go back with the laser. Thank you. It's very difficult.
Oh.
No. No.
There's a Fernando technique for that.
Yeah. Oh, yeah. Good. Perfect. Sorry. Now, the irrigation. Perfect. I would like to see that I didn't forget to remove. Yeah, that's nodule. There is one. There is one nodule here. Yeah, this is a stone. And yeah, and a nodule. Okay. So it's a masterclass on stones. I never used Chromium for stones because I don't do stones. Exception made in the bladder. Yeah. Yeah, ready. So don't judge me.
So you're now using a holmium laser to break the stone, isn't it?
Yeah.
Okay. And that's an advantage of HOLIP, isn't it?
I have a retropulsion.
Βάλε 800 κάτω και πάνω 15. Ready?
Okay. Hmm.
500. Να βάλω τους δύο δεξιά και λένε.
Ouais.
500. 500.
Hmm.
Que je te fais un sous-sac sur le...
Sur le bout du gland.
la queue.
Ouais. Tu me fais travailler en fait.
Ouais. Ça, c'est la surprise. Il avait des liquides intraprostatiques, mais
Ouais.
il avait pas de matière.
Faut appuyer
C'est bon?
sur la. Non, non, sur le laser green light pour pas qu'il s'éteigne. Parce que j'aimerais faire un tour d'hémostase encore. I would like to do a second round of hemostasis before proceeding to the small, the extraction, removal of the remaining nodules. Yeah, that's fine. Okay, that's fine. No need. Yeah.
Stand by for holding.
And green light. One more small round to complete the hemostasis, and now I will be able to emulsonate
Vincent, one question, please.
Yeah.
Have you ever needed to go back with a loop for hemostasis instead of the laser?
I think why I'm going back for the hemostasis, that's the question. Because when the morcellator has a small leakage, in other words, when it sucks more water than it chews some adenoma, I noticed that all the hemostasis can be, all the vessels can reopening due to the suction effect. But it's not a big deal to patient first, and then
You're right, that makes sense, yes, the increased pressure, suction pressure.
okay, nothing is bleeding behind the clothes. Have to pay attention on that. I noticed as well that, but again, no evidence for that, but I noticed that when the morcellation is long, there are some vacuum effect on the bladder, so some small bleedings everywhere in the bladder, like when you have a hemorrhage, vacuum hemorrhage, when you put a catheter in a patient and you remove faster the volume of urine, you will create a vacuum effect. It's the same with the morcellation. When it takes long time to morcellate. Okay, fine. So now I just have to remove the small nodules again. Don't know. Here. We need 4 ends. Yeah. It's always nice to be surrounded by gentle people. Like that. Ah. No. Ah. Ah. Ooh. Got it. Yeah. Perfect. Thanks for the hospitality in the waiting room. Okay.
Doing now. We are a little bit worried in the audience.
Okay. What?
Good morning. So show your both hands, please.
My hands?
Yeah, both. Because we hear someone moaning, we are pretty worried about that. You know, we're not exactly understanding what you're doing.
We were just trying to insert the.
Don't tell you anything to your wife, of course.
Where is the nodule? Oh, here. Where is the nodule? Nothing more. Okay. Irrigation is on. Okay. So No, it's okay. Some small bladder. It will. Okay. Are you agree? So now we can insert the Foley.
Είναι περίμενε λίγο.
No, I don't put.
Bon.
No. Only 20. Okay. That's fine.
Are there any questions from the audience? So we can conclude this operation with a big applause to you.
Thank you very much. It was tough.
Ouais.
Yeah. Tough. Because of the.
J'ai regardé un petit peu quand j'étais en haut, ça avait de très bons plans.
Ouais, mais la fibrose. C'était. Pardon. You turn the mic off. Le plan était difficile. Le plan était très difficile.
So have a little break for the next operation.
So we are ready for action again.
Let's connect to the OR.
Okay, we are connecting, and
Yes. Well, the patient is a quite complicated patient, not only because he has a 100-gram prostate, but he has a very important history of urinary tract infections with the pluri-resistant germs involved. It's under heavy antibiotic treatment since 10 days, 12 days to be precise. This is a very real nice gift from Andreas. This is with the last to have a very big prostate. I hope not to bore you during this procedure. Bipolyp is like the green lip, oaks. Is basically blunt technique. And so as Vincent has made a few minutes ago, we will start leaving the insecurity, the sphincter incising along the veru, and then along the lobes until 11 and 1 o'clock, in order not to transmit any tension to the sphincter. According to an idea of Thomas Herman, we left a slice of untouched mucosa at 12 o'clock in order to spare the urethral ventral plate and to give more sustain and security to the sphincter itself. Okay, so let's go with the killer now. I think that most of you know, which is the so-called Herman loop. This is a small cube, electrified cube, convex on its outer surface. This mimics very well the action of a finger, okay, and it provides a very nice vaporization effect and even better hemostatic effect. Okay, let's go. Okay, so let's start from here, 1 centimeter above the veru. Okay. Okay, there we go. Just to change, to do something different, we will perform a two-lobe technique. So after every incising, along the white line, the prostatic urethral mucosa, we will incise at 5 o'clock. Only the mucosa, you see, without entering the adenoma. You can even appreciate the fantastic hemostatic properties of this loop. Okay. The first one is done. It's basically in continuity with this. I remember that the first of the two parts of the electrode is touching is the active one, so you should avoid touching with the upper part that is a neutral electrode before. Oh, well, let's do it this way. I'm using coagulation because it's a very, very inflamed prostate. I don't want it to start with a huge bleeding. If we were in the bladder and looking toward the prostatic urethra, we'll see that we have encircled the sphincter, and the mucosa part of the sphincter is completely dissociated from the adenoma, as you see here, okay? We didn't enter the gland, we only incised the mucosa. Hopla. Okay. And then we start from 5 o'clock. Okay, so we have divided the whole gland in 2 parts now, okay? Let's try to find the correct plane. Maybe the water will be a little higher. Thank you. You see the plane? This is exactly the same plane that Vincent showed us out before. This whitish with this small perforating vessel, and this is our plane. Obviously, this is a big prostate, so we gotta dig a little bit here to find it. There are a lot of bubbles because the water is not heated. It is important in bipolar surgery. Water temperature is critical in order to reduce the bubbles, you know. Yes, it's better. You see the business? And if you're in the right place, gently, the adenoma is showing to you just in face, you know? Usually, this is much more difficult in small prostate. Only prostate in young patient with the adenoma is not so very well divided from the peripheral zone. I see that I'm going to encircling the adenoma. You see? Obviously, going blunt, you got to perform hemostasis. Any small vessels should be secured in order to obtain a very nice vision, because it is a surgery of details. And you're missing the plane because everything is bleeding. It becomes very hard to retrieve it again. You see? It's like having a finger, you know? It is important in doing so, as Vincent has shown us very clearly before, and all the eminent colleagues that have operated in the morning, you should perform all this maneuver in a symmetric fashion, because if you leave something behind, you will not go the right way, you know? Okay, you see here? Great. It's not as fast as laser, of course. I mean, laser is much faster. Thulium as well, and even green. But has an advantage that no one of the previous techniques has. It is extremely cheap. Because basically, apart from oscillator, there is no specific device to be obtained in your armamentarium. You're using a 26 French continuous flow stored resectoscope. I do prefer a 12 degrees optic, but if you're accustomed to use a 30 degrees, obviously there's no difference. It's a matter of preference and habitude, you know. Our task is to gain in the going along the proper plane the incision that we perform at 1 o'clock. We are not exactly just around the corner, but anyway, we'll get it. Surfing on the plane between the adenoma and the peripheral zone, the big vessel of the prostate are, yeah, we did a mistake, you see. We did go a little bit too toward the capsule. You gotta follow another plane here. And if you find a plane and the plane is compass is easy to follow. Don't be afraid. Follow it until the end. Sometimes not so easy, basically, because especially in this case, I'm waiting for areas of great resistance due to the previous infectious disease. But maybe you're lucky. You see, I got a free a little bit along this part. Along the incision, but not so bad, you see. I don't think this is 100 grams. No, minus. No, I don't think so. The orifices, I saw them before, were far away, okay? I'm moving along this way, okay? Well, going the other way around, you know, following this plane. You see, this is your road map. This whitish tissue with the small vessels seen in transparence, you know. This is the mistake we did before. I did. If the prostate resists you, you call the cutting power, and everything is set and fixed. Remember the golf player? I'm not going to and fro, but I'm circling around the ball, you know? Now I'm going up and try to find my incision that is here. Okay. But the technique, as you can see, is exactly the same, irrespective of the power source you are using, you know? You see, this is the plane, small vessel in a whitish background, you know? Right? You see it? The sphincter is just behind our shoulders, so we're not transmitting any traction to the sphincter. Up. You like Andres? It is. It is. We're lucky. Huh? Yes. Yes, it's a gift. You know, gentlemen, the plane is nice, huh? Isn't it? And basically, this was the sort of illumination that I have many years ago. The instrument is not working. No. When I was in Paris, no. No. Probably yes, start. Yeah, start it again. We're starting the generator. This is not the procedure that is bloodless. It's the plane that is bloodless. If you follow the correct plane, it's good, right? You're working. Thank you very much. And in this setting, you know, we can think that probably bipolar in this case for QRP is another, or QRB is another matter. But in this case, I don't think that bipolar makes the difference, because if you see, you utilize a very, very small amount of energy, and probably even a monopolar probe will do a nice service. But I was something more or less the father of bipolar surgery in the neurologic endoscopy 20 years ago. And I'm proud to inform you that it's a matter of days. There will be published a silver book from Storrs concerning the bipolar bipolar technology. It's a very long story, but at last we saw the light. And so I'm very fond of bipolar in all the expression, And my interest in bipolar started by chance because many years ago we have a very important electrical problems in the hospital where I worked at that time, and so we bought a bipolar generation, the Acme Vista CTR, without exactly knowing what we're talking about, what we have in hands. And in that period in the hospital, there was a lot of engineers, physics, and so on. And so I tried to understand, and I became a false expert, I supposed to be expert in the field, just trying to understand a word that was very far from my knowledge and competence. Okay, let's go. This is the other side. It is. The only real difficulty in this surgery is to find and follow the plane. And if you see, the plane is perfect here. We did a little mistake here. We can turn the instrument up. The settings here are not so critical because the system will give you exactly the power that you need. So you can set it as a standard TRP, and the system will do the same, the rest. You see, this is the landmark. This is what you're seeking. This is what you gotta follow, okay? If for any reason you lose the plane, and usually the beginner goes into the adenoma, usually the so-called expert, or a presumed one, goes to the peripheral zone, and you find a big bleeder, don't panic, because this system is absolutely excellent in dominating either a very big arterial bleeder. Please do not open venous sinuses as well. But in case the problem is not so difficult to fix, Okay. Like, folks? Good. Okay. I'm going a little bit slow because I want you to realize what I'm doing. My airplane is tomorrow morning, so
Everybody was laughing with that. Thank you.
Pardon?
Everybody was laughing with that. So the other comment from us is that Dr. Andreus knows to choose what patient should be operated from what doctor. In this case, it seems to be a case for the big boys.
Yeah. Yes, this is called a gift. There's an expression in Italian. Where is the guy? The guy who graduated in Italy. Are you here? Graduated in Italy. This is a colpo di culo. Yes, if you want to translate in Greek.
I understand. I know very good.
Yeah. No, it's a good luck, you know.
Ah,
Yes.
yeah, that's what we were saying. We were playing together. Good luck. to each
Yeah.
other.
Yes. I will be very happy to find the light of the bladder. Sometimes going this way, if you're not going in the correct plane, you go to the other side, but it's not a problem. But we try to go down this way. Oh. Another trick in the bipolar surgery is that the hemostasis should be done exactly on the bleeder, not around, not a little bit over, lower or upper, but on the target. Hop. Good. The other way. Because another option is to, if you're not able to do it this way, to free completely the lobe and then going medial to lateral. It's another option, you know. Even if probably on the upper side is still, no, it's not bad. It's not bad, the effect. Okay. Blah. Don't want me? I find you another way. Hopla. You see that here it's not very well. Oh. Any question?
Everybody's admiring.
Pardon?
Everybody's admiring.
question for the moment. We have a very clear view of your operating field, no bleeding, so we're able to follow with you to the operation.
If you are made a tearing of the capsule, and in this case, it's better you go a little bit slower and to detach the adenoma nearby, coagulating, in order to reduce mechanical traction, not to widen the gap that in this case is absolutely uneventful, you know. And as you can see easily, I am only doing this movement, okay? Surfing. I'm not able to surf, not the physique of the American and Australian surfers, but anyway, I was a former rugby player. Surf is another matter. So you see, we are very near here. And it is the plane that is avascular. It is not my technique that is avascular. Makes the operation avascular. Okay, you see the light? Light, okay? Yes. This is the bladder, of course. It is supposed to be. And now from here, you see that we are free from 12 to 2 o'clock. Okay, good. Now the point we are a little bit on delayed is here, but I try to turn the instrument upside down. And then going along the bladder neck, you know.
I'm afraid that what you are doing will convince my colleague to convert from polyp to bipolar. And so we're trying to buy a new laser.
No. Well, I am very devoted to laser. I like it very much. I'll be honest. I start with bipolar. I do bipolar, but holmium has taken my heart, you know. But I think I'm still doing it because as much as I'm doing all enucleation, I become a better bipolar enucleation and vice versa. It is very, and this, because the technique is always the same, you know, it's always the same. There is no difference. There are very small details, but the substance is the same, you know. Opla, completamente libero. Vediamo se è tutto libero. Oh, chi c'è? Is Rebel. We got to check if it's completely free, because sometimes you became crazy at a certain part of the operation because the adenoma is not free. Okay, let's go here, for instance. Yeah, there's something that's still attached. Okay. I think there is something here that's still resisting. So there is something on the middle aspect that is resisting. Let me try to find it and shoot it down. Well, and this is the convexity of the convex aspect, outer aspect of the loop that is very, very useful in this setting, you know, because it's not a cube. It's not a cube. It's not an hemisphere on the outer aspect. It's not to undermine the bottleneck. Okay, up. Okay. This is the other side. So allora. Wow. There's still something on the upper part. Where? Where? Okay. It's gone. Or no, yes. One down, one to go, okay? Obviously, the other part is a little bit easier, even if it's a little bigger, but you have more space, and so the irrigation is better. You see the fossa is smooth, large. You can vaporize these devascularized small fragments. Okay. Let's go on the other side, okay? It's a gently traction, you know, because if you are on a plane, you follow the plane. As Kenny Lally from Berlin says, you should love the prostate. I don't love the prostate, but I understand what she's saying. You gotta treat it right. See, the rest is very nice. So it's very easy. It's not difficult. Want to try? Want to try? Okay. Okay. Are you Jew? All right. Good.
We have a question from the chat. And the question is, do you have to put force or just to push? Do you have to put force?
Protocol.
Are you putting a lot of force or you push it gently to the tissue?
No, not a lot of force. No, it's a gentle maneuver. It's a gentle maneuver. It's if we can go back to the time of open simple prostatectomy, is more or less the tension that you apply with the finger is following exactly the same plane. No, it's not so much. Not too. It's not necessary to apply too much strength, because if you see, we don't have the CO, the CO2 in laparoscopy and robotic that opens the plane, but water does something like that, if you are on the correct plane, of course. You see? It's not important not to go too far away on the outer aspect of the gland. You should remember that the adenoma is a ball. Prostate is a ball. Adenoma is a ball in a ball. And so you got to imagine where the plane could be. And when you find it, follow it. You see? It's like the rope of Arianna in the labyrinth of Knaxo. Was it Knaxo, the labyrinth? Yes. The labyrinth was in the Knaxo palace, no? In Crete.
Yeah.
Yes. Obviously, you should be exaggerated in hemostasis because during a TURP, these vessels wouldn't be, they would be ignored. But in this case, it's very crucial to secure them because blood makes the vision of this delicate plane difficult, and most importantly, for making a safe constellation, your vision should be clear. In my hospital, it's a long time now, we do not check hemoglobin level postoperative in these patients. Not for this, not for onion. And the patient discharged usually on postoperative day 1. You see? Always the same play and following it.
We don't just see, we believe now. We are
Really?
believers.
I don't only see, they believe what you're saying.
Yes. Hopla. I coagulate this vessel only because if I made a gentle traction and they are involved in the traction, they will not bleed. Yes, good. All right. Bladder neck is here. This technique obviously has a wide indication in, for instance, where I worked before, small hospitals who cannot afford 100,000 euros for a laser, and particularly having a wider horizon in the developing countries, you know. but you can offer all the advantages of a enucleative technique to people who cannot afford the purchase of a brand new laser.
What about the irritative symptoms post-operatively? You are
No
using
one.
very
Very unusual. Basically, they are not a problem. If the patient doesn't have an urgent incontinence before, but symptoms directly related to the procedure are negligible. Because bipolar current has a dispersion range of 0.4 centimeters, 4 millimeters at more. But it's a bipolar, and so it's not so hurting, you know? And irritative symptoms related to the procedure are absolutely sporadic. At the beginning of the experience, I asked the patient, "Sir, how do you urinate after the operation?" Like before. And I was very disappointed because I thought that it was voiding with difficulty, straining, and excitation. It means that they have no particular discomfort related to the procedure, you know. And as any enucleative technique, stand the test of time. At the end of the procedure, we'll show you a picture of the sonography of a bipolar performed 5 years ago. And the fossa is fantastically wide. You see that both electrodes are activated now. So you gotta check that your target has been shot, you know. You like it?
We love it.
Now I was asking to this beautiful young lady just beside me that yesterday night was beside me at the restaurant, and I was a very worst guest because I don't speak Greek. She doesn't speak English, and so the communication was very difficult, you know. So I feel guilty. Try to translate to her. Do you?
Don't worry about the communication with the Greek ladies. My wife is speaking Greek, and I never understand what she's talking about.
I was incredibly ugly, you know. Now you told me that you don't understand.
So as we can see, I think that there is now this workshop is and masterclass is very interesting because actually we have two real different technique, I think, between what we saw this morning and what we see this afternoon.
Yes, you're right. But the family, the surname is the same. The Christian name is different, but the surname is the same. They're all of the same family.
Yeah, it's the same family, but we see that we can approach the enucleation of prostate in two manners, probably a lot of laser using, and a blunt dissection completed by hemostasis with the green light or the monopolar or the bipolar or whatever, or the thulium or the holmium I think it's two different way to see enucleation in terms of dissection, but both are very nice, I think. Huh? But
yes, I totally agree with you. I totally agree with you.
yeah.
But this is a technique that at the beginning of the experience, I tried to do with a standard loop, and it's feasible. It's a little bit boring, of course, it's slower, but just for trying to do that and see the effect, if you're able to fold the plane, you can do it with a simple resection loop, You see, this is much easier because the adenoma can be displaced easily because there is more room, So you speak English?
What we see is definitely that with the bipolar, the hemostasis seems to be excellent too. Huh?
Absolutely.
Yeah, you always have a very good vision. Even if you do blunt dissection, you're always in a very clear operating vision.
And no charring.
And no charring.
Yes. And it's a very stable hemostasis because at the beginning of the experience, many friends, colleagues told you, no, I'm not sure that this bloody instrument is doing a proper action because I don't see charring. You can if you can wait for a century, probably a charring will appear, but this is not the way that the bipolar works, the charring,
No, the only remark I have to make on this is what about continence, especially for elderly people? Have you got some problem because of this mechanical dissection and pushing? Do you think it's possible to injure the sphincter? When you manage this, what is your experience about incontinence?
It is. We didn't have any so many cases of incontinence, but at the beginning of the procedure, it's absolutely mandatory that you free the sphincter. You leave the sphincter, and so you can push without injuring, without teasing it. It is the same maneuver. We did the same maneuver that Vincent has made at the beginning of this procedure. Pericollicular incision and incision along the prostatic urethra mucosa, just to make the sphincter to flip back, and go out of the way. One of the worst results I had was a very big friend of mine, 2015, yes, 16, at the beginning of 16, and was completely incontinent. But after 3 months, I put it in advance, and he's still my friend.
In patients that have incontinence after this procedure, what is usually the cause? It is problem with the sphincter, or it is the scarring to the mucosa? It is the mucosa to mucosa affiliation that is not working.
Well, slight incontinence usually is related to mucosal tearing, If the patient is a huge important incontinence, is usually is related to a section of the muscular part, But slight incontinence usually resolves spontaneously in 8 weeks, 12 weeks. The same thing with the laser. It's actually the same. Okay. How are we doing here?
Consider from oscillation, you want the right or left?
Oh, left is usually left. Hopla. Hop. As you can see, we are acting on the adenoma. There's starting bleeding here. Here's something still attached here. So, hopla. Ah, yes. Hop. Okay. That's good. Allora, let's do the all around. Go, merry go around. Here, free. No, is it free? Yes. No. There's something. Small pedicle probably. Yes. Eccolo qua. Here it is. At the beginning of your experience, when this stringing adenoma, it's difficult to maintain to be calm. In this situation, this loop is not exactly perfect, but everybody has some defect, Okay, let's go. Let's have a look. There is a bunch completely devascularized, they will fall. And urodynamically are absolutely unimportant. Will you please be so kind to clean the loop? Okay. So what's your name?
My name is Helen.
Pardon?
Helen. My
Helen.
name is
Ah,
Helen.
yes, that's my sister. My daughter. No, my sister. Opla, vediamo. Sì, dai, va bene. Ok. Ok. Obviously, one disadvantage of the two-to-lobe techniques is that you got mostly two different pieces, but it's not so dramatic an experience,
Having two pieces is an advantage or disadvantage?
Disadvantage. Yeah, disadvantage. A slight disadvantage.
If the piece is too large, then it's not really easy to oscillate.
Yes, and basically many times you break into two parts, so you have two lobes in. Okay. What say, Andreas? It's fine. All right. Good. Ready? You gotta take away the sheet or not?
Just to take away this.
The sheet, yes. This is okay. That's good. Helen? Okay. Let's go with the modulator. The pedal is this. Okay. Shame. Okay. Bye. Ready? Okay. Thank you. Is it ready? boys. Can you put it a little faster?
2005.
Yes, please.
Yeah.
Thank you. We're finishing. Hop.
You are going really fast now. What is your rotation speed at the moment?
It is 2,500.
Sorry?
2,500 the oscillator.
Okay, thank you.
You please be so kind to slow it down just a little now. Slow it down the oscillator. Bring it back to 2,000, please. Thank you. Good. Thank you very much. If you slow down the velocity of oscillator, suction is prevalent, so the pieces tend to be more fixed to the instrument, you know. Okay, I suppose there is some more stuff to. A very nice help would come from the online real-time sonography. All my scrub nurses are able to perform a sonography, and having the sonography during the procedure is very nice. What do you say, Andreas? Do you say anything else? No? So on the suction, according to my opinion, we are finished. Okay, good. Doesn't it? Shut it down. Okay. Good. We're going to wash it with the syringe. Usually, say syringe. Yes. Usually, I put the catheter. It's about 60 on the bottom of the neck with a small fraction, and then goes. Yeah, 40, 60. At the end of any enucleating technique, the urine at the end are always dreadful because there are a lot of blood coming for the adenoma. Okay. Let's go for 50, yes, 50. You have to be complimented because you're an excellent staff here. Excellent nurse staff, you know.
I don't know if you understand English. Forgot. Excellent.
Let's try to wash it just a little bit with that syringe.
You're gonna like
Even a bit more. Thank you very much. And now a wet dose.
Victoria.
Reasonable, isn't it? Good. Sponge, a small sponge. No, little one. Yes, that's it. Okay. Would you like to open it completely? Okay. Make a string. It's a little bit small. Okay. Yes. We got a knot. Straight. Fix it. Fix. Stronger. Ay. No, keep the catheter. Yes, okay. And put. Okay. No, c'ho una gatta più grande, larger one. Do you have a larger one? But what, Andrea, guarda, it's fine without any traction. Huh? What do you say?
For a little bit for the beginning.
Yes,
If it goes up.
No, I don't know. It's fine. Thank you very much. Okay, thank you very much. And sorry for the yesterday night. Okay. I was an ugly. Yes.
Okay. So
You could tell me that your friend speaks
conclude
English.
this procedure. A big
Pardon?
applause from us in the audience.
Thank you. Thank you very much.
Thank you very much. Thank you
Thank you.
to everybody that has participated in this session.
Please
And we are
continue a
waiting
little
for-
bit for the questions. We are going upstairs, and we will close the session in several minutes after our discussion.
We're down for discussion?
So we're waiting for our speakers to come from the operating rooms. Would you like to comment something from the audience? Questions or comment? We are very lucky today. we have to see people that are really proficient, have really proficiency in what they are doing. We had the chance to see different approaches to the same problem. As you have everybody understand until now, it's the same problem that we can access in two different ways. We can either use the energy to develop our plane, or we can blindly dissect our plane and use the energy just to control the bleeding, or in a few cases to cut the tissue if there is no plane. It seems that the result is the same either way. It can be with excellent results no matter of the technique, and it's up to the surgeon to choose what he likes to do and always take in account what is available and what is cost effective according to the place that he is working to, or the number of the patients that he has to treat. For example, as we have been told today multiple times, if you're gonna have one laser for everything, you have to choose what? The thulium one. Is this correct? Okay. If you need the best laser to do enucleation of the prostate, but it will be good only for that, then the HOLEP is a better choice. If you don't have access to any kind of laser, then you can use your bipolar to do a perfectly good enucleation. If you already have the green light, you can use that. So it's up to the surgeon. The only thing that really is necessary is the oscillator. And today we were lucky because it was working perfectly all day and it was very fast. And usually this is the case. So I would like to call Dr. Andreou now. To the chair, and we'll have a short discussion about the difficult cases and the limits of endoscopic enucleation.
Well, in fact, I would like to thank everybody for their effort for this first time meeting, comparing all the different techniques for the endoscopic enucleation. We saw a lot of things. We admired our colleagues, and congratulations to everybody. Jean-Baptiste Roche, ici, Dr. Misrahi, Dr. Gomez-Sanza, and Dr. Meneghini. I'm not sure what to choose now. I told Dr. Meneghini when we were downstairs at the operating theater that I'm afraid that with his perfect technique, he will convince Dr. Bekos to start by POLEP and leave HOLEP. And it would be a great problem because we're trying to buy a new laser. So I need his to push with me. I really don't know which technique is the best after this day. And I think we'll try to make a vote for all those that are looking online and all the participants here in this room. And we'll see what we decide to do. Concerning difficult cases and the limits, I don't know. I think the sky is the limit for HOLEP or other endoscopic techniques. I'm not sure there is a limit. It's sure that open prostatectomy is probably history now, when we see what we can achieve with endoscopic prostatectomy. And I think we had a very, very nice meeting. If you have any questions.
Can I just make a comment? I believe that the case Dr. Meneghini performed was a really difficult case. Having some small experience with bipolar, especially on the left side, the planes were stuck. On the right side, it was quite more easy rather compared to the left side. He did a great job. And I agree with what Dr. Ross mentioned earlier, his comment. During this day today, we've seen two different techniques arriving at the same result. However, with thulium and holmium, there was less touching of the tissue compared to what we saw today with bipolar, of course, and with green light laser, where there was a lot of blunt dissection, of course, through the right plane always. And this is just a small difference between those two techniques, the thulium and holmium laser, using more energy and less pushing of the tissue, less manipulating of the tissue, compared to what we've seen today with Dr. Misrai actually doing half of the surgery just by pushing on the right plane. The other thing, just a small comment, I have to praise Dr. Andreu and Dr. Bekos for their effort to disseminate and push the use of enucleation. I'm happy that there's a lot of us today, physically and on the internet as well. So this is a good start. And we have plenty of choices, as you have seen, laser choices, bipolar choices. It's really up to you and the budget that you have in order to start doing enucleation. You have the options. You've seen the masters today, and you should probably think about starting your experience in enucleation.
I have another comment too. So first, I was very happy to be here for this first edition, and I'm sure that it's not the last one, for sure. We have a great article from Thomas Herman who say, education is enucleation is enucleation. We all know that Bible paper, all right? And I would have to add a comment, because for enucleation, I think we have to add education and education and education. And thank you for that, because it was a great moment of education for these 2 days. Thank you.
So thank you, everybody. I think we have to close this meeting. There is simulator training for everybody interested to finish at 6 o'clock. And Dr. Bekos.
One last question to Dr. Meneghini. What were your settings? What were your settings?
No settings for bipolar.
Okay.
Bipolar is be considered a sort of Cinderella of the enucleating technique.
The microphone, please.
Yes. As being
Consider the Cinderella of the enucleating techniques, because it's economic, is simple, you know. And Cesare Scofone told me that this is the laser of the poor man, you know. You don't have the money to get a laser. You're a poor man, you should do it by polyp. But the story is a little bit different. I think this is a nice way to start, to enter the stage, because it's easy. It's not so economically heavy for the award. And if you have any doubt if enucleation is a good choice, I think the bipolar could be a nice topic to decide that yes. Well, you get thulium, you get holmium with evergreen. No, it's not important, but probably to enter in the on stage is a nice option. And I see this was a relatively huge prostate, but I think the result at the end is fine. The urine clear, and patients lost a few 100,000 of red blood cells. You know, it is absolutely uneventful. I want to thank you very much, you all, for having invited me with this very high-level panel. I'm not at the same level of Jean-Baptiste Roche, Fernando, and Vincent, but I'm very happy to be here, and thank you very much, you all, and see you next time. Thank you.
we were really impressed by your technique, dear Ago. So everybody in this room is saying the same thing. So I promise I'll see you next year. I don't know where, Thessaloniki for gastronomy, or Bordeaux pour le vin, or Venice, or Madrid.
I'm a certified sommelier, so Bordeaux is fine for me.
Okay, see you next year. Thank you very much.